This is a simple algorithm for pulmonary thromboembolism. Patients with low clinical suspicion are those that are ambulatory without risk factors for pulmonary embolism, that have a respiratory rate less than 20, normal PO2, no signs of pulmonary hypertension. If in these patients we're interested in ruling out the pulmonary embolism. The second category would be the high clinical suspicion, which include patients with risk factors for pulmonary thromboembolism, a patient with tachypnea, that is respiratory rate more than 20, decreased arterial PO2, or signs of pulmonary hypertension. Low clinical suspicion. We always have a chest radiographic examination, and the D-dimer is to be considered. When it is less than 500, there is no pulmonary embolism. When it is more than 500, then the algorithm depends on the results of the chest rentgenogram. First, the D-dimer. The ELISA technique is recommended over the latex agglutination test. The D-dimer is a protein formed by the fibrinolytic process, the normal repair mechanism that is responsible for thrombolysis. When the D-dimer level is less than 500 milligrams per deciliter, the presence of thrombosis can be excluded with a negative predictive value of about 98%, and no further workup is recommended. Some believe that it is important to emphasize the ELISA technique versus the latex agglutination. If the latex agglutination test is used instead and the result is negative, one should always try to confirm the suspicion with the ELISA technique. Elevated D-dimers levels of greater than 500 milligrams per deciliter are detected when thrombosis is present, but this finding is not specific for pulmonary thromboembolism or deep vein thrombosis. Most inpatient, especially postoperative patients, will have elevated D-dimer levels without evidence of a pulmonary thromboembolism or deep vein thrombosis. And this is the reason why the D-dimer level assay is recommended for outpatients or for patients without risk factors for pulmonary embolism. A positive D-dimer test in a patient in whom we suspect the presence of pulmonary thromboembolism indicates the need for further work. In patients without pulmonary disease, that is a negative chest rentgenogram, ventilation perfusion scan will be considered again if the D-dimer test shows a value over 500. The result of the ventilation perfusion test should be normal, high, or low / intermediate. If it is negative, then there is no pulmonary embolism. If there is a high probability of pulmonary thromboembolism, one should start treatment immediately and then search for the source. With the situation, which is unfortunately quite common, of low or intermediate probability, one should consider the use of computerized study of the pulmonary vasculature, that is CT arteriography, and if the contrast material that is utilized is contraindicated, then we should use ultrasound of the lower extremity. If a patient is known to have pulmonary disease, that is the chest rentgenogram is abnormal, one should proceed with CT pulmonary arteriography and obviously supplemented with CT venography. However, some patients, the contrast material may be contraindicated, in which case we should then go to sonography of the veins of the lower extremities. With CT angiography, clinically significant pulmonary emboli can be recognized independently if there are other abnormalities in the thorax. In addition, with CT, one can identify other pathologies in the lung, particularly interstitial lung disease, that may explain symptoms such as dyspnea. And one can evaluate the progression of pre-existing lung disease or explain the abnormal radiographic findings, if any. High clinical suspicion are those patients with risk factors for pulmonary thromboembolism, patients that have tachypnea, that is respiratory rate over 20, decreased arterial PO2, or signs of pulmonary hypertension. If a patient has no contraindication to the use of contrast material, CT pulmonary angiography slash venography is to be considered. If the administration of intravenous contrast material is contraindicated, there is no known history of pulmonary disease, and the chest rentgenogram is negative, then a ventilation perfusion scan should be performed. If the VQ scan is normal, then pulmonary embolism can be excluded and no further workup is necessary. On the other hand, if the VQ scan results in low or intermediate probability, then an MR angiography with or without the use of gadolinium, with or without MR venography, should be considered, and this is the new trends in patients with high clinical suspicion. When the VQ scan shows high probability, one should start the treatment for pulmonary embolism and seek the source. And the source is to be looked for using sonography of the veins of the lower extremities. When intravenous contrast material is contraindicated, the patient has pulmonary disease or there is an abnormal chest rentgenogram, MR angiography should be considered. An MR venography can also be performed following the examination of the pulmonary vasculature. If the MR angiography is positive for pulmonary embolism, the treatment should be started immediately. If venography is not performed, then the source has to be located. If CT venography was not performed, the study recommended is Doppler sonography of the lower extremities, since this is the origin of 90% of the emboli that go to the lungs. If the Doppler ultrasound of the lower extremities is negative, other sources should be investigated, such as the upper extremity veins, the right heart chambers, the inferior vena cava, and sonography of the upper extremities and or echocardiography are the next steps to be followed. Upper extremity and intracardiac thrombosis are predisposed by central venous catheters, pacemakers, and remember always that intracardiac tumors can also be a source of emboli. If echocardiography is not technically adequate or non-diagnostic, then cardiac MRI may be useful to rule out intracardiac pathology. If the upper extremities show no evidence of thrombosis and the cardiac study with ultrasound is negative, then primary thrombosis of the pulmonary arteries or non-thrombotic pulmonary emboli should be considered. Remember that in patients who have pulmonary thromboembolic disease, there can be a secondary thrombosis due to stagnant blood flow. So we then combine a primary thromboembolic phenomena with a secondary thrombosis. The same thing happens in patients who have any type of pulmonary hypertension. Structural changes in the pulmonary vasculature may predispose to in situ thrombosis of initially normal branches of the pulmonary artery. With CT angiography, clinically significant pulmonary emboli can be recognized independently if there are other abnormalities in the thorax. CT venography is usually performed after CT pulmonary angiography and is utilized to evaluate the peripheral venous tree from the level of the renal veins to the popliteal veins, and it will exclude deep vein thrombosis with the same or even more efficacy as Doppler sonography. There are four possibilities: that both studies will be positive, that both studies will be negative, or either one can be positive and the other one negative. If both studies are positive, one should start treatment without any further workup. On the other hand, if the CT pulmonary angiography is positive but the CT venography is negative, one should search for other sources. If the pulmonary angiogram with CT is negative, but we find thrombosis of peripheral veins, one should treat the deep vein thrombosis. If both studies are negative, then no evidence of pulmonary embolism should be considered, and there will be no need for further work.